Okay, right. We have two lectures. One is about larynx, pharynx, and tumors in ENT. Now, why do you want to know about this area is exam wise, there will be some areas for you to know. At the same time, as a clinician, this area is very important because it shares the airway and one of the most common cancer pathology in Sri Lanka. So at the end of this lecture, you need to learn the anatomy of the larynx and pharynx for you to understand the clinical setup. And you have to learn the clinical conditions of the larynx and pharynx with what is their presentation and to learn common tumors in the ENT. So we'll be mainly focusing on to the conditions or clinical conditions of the larynx and pharynx and what are the common tumors in that area. So if you can remember your anatomy, we have airway or the upper airway has the nasal cavity. Then we have three areas in the pharynx. They are called nasopharynx, oropharynx, hypopharynx, and larynx. So these are the areas that you have to remember about this airway related to airway. So up to the level of the soft palate, from the end of the nasal cavity is the nasopharynx. From there to the tip of the epiglottis is called the oropharynx, which is correlating with the opening of the oral cavity. Then you have the hypopharynx, which is behind the larynx, and that opens into your esophagus. In the front area, you have your larynx, which contains the vocal cords and all. So, larynx is actually a muscular cartilaginous structure. If you can remember anatomy, larynx has muscles, cartilage, and some ligaments and membranes. So that is the that opens from the airway into the from your oral cavity. It connects the superior part of the trachea to the pharynx. Inferior to the tongue and hyoid bone. So it is there inferior to the tongue and the hyoid bone, if you can remember your anatomy. It's a essential sphincter guarding the entrance into the trachea. So that acts as a very significant sphincter where the amount or the food that you are going to eat, which goes into the esophagus, because of this larynx, it does not go into your trachea. And at the same time, it works as the organ of the voice as well. So it is formed by 9 cartilages, if you can remember. And then it's formed by ligaments and muscles, as I told you. So this is the picture of your larynx. I hope you have learned this, and if you have gone to ENT appointment, you might have seen this. You can see here in my pointer, you can see the epiglottis, you can see the true vocal cords and false vocal cords. This is the enlarged view. You can see the true vocal cords and false vocal cords. Arytenoids, this is the opening of the esophagus, this is the opening of the trachea, and this is called the piriform fossa. Either side you have the piriform fossa, arytenoids, epiglottis, and eriepiglottic folds and valleculae. So these are the major anatomical structures of the larynx you have to remember. So this is the diagrammatic representation. That one was the clear natural picture. You can see the same on a diagrammatic representation here. So when we are in a clinical setting, we have to look at the larynx. So there are few methods of examining the larynx. This is called laryngoscopy. So this commonest one which you all know is the indirect laryngoscopy. Indirect laryngoscopy means you use a laryngeal mirror and you use some sort of light source which reflect onto the laryngeal mirror. So nowadays, actually, we have headlights. You might have seen that headlights giving light reflection onto the putting directing light onto the mirror, which is held by the clinician, where the patient is putting tongue out, and you are putting the laryngeal mirror, which is little preheated to prevent mist formation, and you are looking at the larynx where you get the reflected image of the larynx onto the mirror. So those days we use bullseye lamps with the head mirror. That is whenever you saw a ENT surgeon, those days it's a surgeon with the mirror on the head. Nowadays, of course, we do not use mirrors, we use the headlights. So this is the way of that you see the larynx on an indirect laryngoscopy. Some of the centers still practice indirect laryngoscopy where the facilities for other sophisticated examination methods are not there. So you might see sometimes the indirect laryngoscopy. So this is called intubation laryngoscopy when you are going for your theater clinical appointments. They look at the larynx to put the tube, intubation tube, in between these vocal cords to give the patient general anesthesia. So this is called intubation laryngoscopy. So what we use now basically is the fiber optic laryngoscopy. We have a fiber optic scope with a light and a camera which goes along the nose or mouth and get a very nice view with a real-time examination. So it's a office-based procedure where you can do it as a OPD procedure under local anesthesia. Patient come and get the examination done and go home. And very minor procedure. But the amount of details that you get is enormous, and you can do some few procedures as well with this. Like you can do some biopsy procedures and vocal cord assessments, and sometimes foreign body removal also is being done under this procedure. There's a video, I don't know, hope, yeah, it's running. So you can see the area of the tongue, area of the valleculae, both sides. You can see the uvula is pushing down, and you can see the nice view of the larynx. You can see the two vocal cords, false vocal cords, and the area epiglottic folds, and this is how it comes out from the nose. So you can see it's going in again through the nose, and then so that is the procedure. There you can see the vocal cords and examination nicely. Here you can see it's going in. Postnasal space, enter into the larynx. You can see the movements of the vocal cords. Where you can see the proper anatomy of the larynx there. So next procedure is called direct laryngoscopy when we want to examine the larynx and do a major procedure like a biopsy or removal of a big foreign body or removal of the tumor. Those type of things actually we can't do with the fiber optic laryngoscopy where the patient is conscious. And then this procedure is called direct laryngoscopy where you examine and do the procedures of the patient. So then we will move into the conditions that you should know in the larynx. Commonest thing is the laryngeal carcinoma, where you can see specifically in an area like us where the smoking is more and beetle chewing are the risk factors. You can see irregular growth over the vocal cords. If you do a CT again, you will see the irregular nature of the growth, and you can see the nice smooth vocal cord on the other side. So the commonest carcinoma is squamous cell carcinoma. They will present with hoarseness of voice. Majority of the patients, initial presentation is this hoarseness of voice. So any patient who's having a hoarseness more than 2 weeks need a laryngeal examination. So the commonest cause of the voice users like teachers, singers, and those type of people, it's called vocal cords nodules. So if you look at the vocal cords, the commonest area where the vocal cords touch each other is in between the anterior 1/3 and middle 1/3 of the vocal cords. If you divide the length of the vocal cords into 3, you can see the nodules appearing in between the anterior 1/3 and the middle 1/3 of the vocal cords. So this initial stage, if you diagnose them, you can give physiotherapy or speech therapy, to be honest. Speech therapy, and then you can give some exercises for the patient to do and teach their vocal hygiene and methods of talking and all. You can prevent a surgical procedure. But if the nodules are being a little harder, you have to do a microlaryngoscopy, a surgical procedure, and removal of the nodules. So it's your duty, if a teacher or a voice user comes to you with a voice change, you have to be aware that this can be a vocal cord nodules and proper examination is needed. So in smokers, actually, you can get a condition called Rinke's edema, where the vocal cord is quite significantly edematous and like bag of water, very difficult to treat. And whatever we do, they end up with quite significant permanent voice change. So the advice is cessation of smoking. So this is the look that you can see. View, you don't have to know very much details about, but a condition called Rinke's edema is a possibility. So other common pathology of vocal cord is vocal cord paralysis. It can be either unilateral or it can be either bilateral. It can be recurrent laryngeal nerve palsy. It can be superior laryngeal nerve palsy, which is a branch, which can be a branch of external branch of superior laryngeal nerve or internal branch. So external branch of the superior laryngeal nerve supplies the cricothyroid muscle, which is the tensor of the vocal cords. If you get external branch damage, you will get voice reduction, specifically the high frequency, because you can't tense the vocal cords if you get a superior laryngeal nerve external branch damage. If you get a damage to the internal branch actually supplies the sensory supply to the upper part of the larynx. So they might get chronic cough-like thing because of the rigor aspiration. If you get an internal laryngeal nerve paralysis. But recurrent laryngeal nerve is more significant than that because recurrent laryngeal nerve, if you get a paralysis, you get a vocal cord palsy. So it can be abductor palsy or it can be adductor palsy. So if your vocal cords are not abducting, that is the most significant vocal cord paralysis because if the cords become adducted or come close together, they will not be able to breathe adequately without having the airway compromise. So if it happens into a unilateral or one side, they will end up with some voice change, and that is not a major issue. You can treat them with some speech therapy or some procedures, surgical procedures, where you can do fat injection and sort of medialization of vocal cord. So many procedures that you don't have to know. But if you get a bilateral vocal cord palsy, they might get a acute upper airway compromise. So that condition is a medical emergency. So the commonest causes of bilateral vocal cord palsy are following total thyroidectomy. So you have to be aware the cause of the recurrent laryngeal nerve and strategies to prevent bilateral vocal cord palsy if you are planning to be a surgeon and if you're planning to do thyroid surgeries. So, if there is a trauma to your recurrent laryngeal nerve, moderate level, only the abductors are going to paralyze. So, this is called the Siemens law. Just for your knowledge, if you get a mild traction injury, your abductors are going to be paralyzed. Then your vocal cord may be in an adducted position. So, that is the worst scenario. So if you get bilateral vocal cord moderate trauma, then you are in trouble. In that case, it is better to have a cut injury to the vocal cords because then you will end up with both adductors and abductors paralyzed. Then you will have some sort of a airway for the patient to breathe. So this is a very important area that you have to know, acute airway compromise. So acute airway compromise is the cause narrowing of the upper airway leading to compromise of ventilation. So that means not adequate air is coming into the patient's lungs. So it can be acute, it can be chronic, it can be congenital, or it can be acquired. It can be partial or complete. So airway compromise, if it is acute and complete, that means your patient's airway is completely shut down. So you need to talk about some other airways, surgical airways in that patient. So airway compromise in the upper part of the upper airway is not a major issue. If you get a nose block, nasopharynx or oropharynx area, patient will be breathing through the mouth. But if there is a significant blockage in the hypopharynx and larynx and trachea, they will be into a significant upper airway compromise status. So in that case, you will get a noisy breathing. So a noisy breathing which happens due to the nose and nasopharynx and oropharyngeal airway compromise is called stertor, snoring, something like that. But if you get a compromise into the lower part, that's the hypopharynx, larynx and trachea, they will get a condition called stridor. That is a medical emergency. All the medical doctors should know about stridor. So they will present with either inspiratory stridor, either expiratory stridor or biphasic. So that means stridor during inspiration, stridor during expiration, or stridor during both inspiration and expiration. Stridor is a musical sound which is high pitch, like something like that. That's not exactly one, but it is something similar to that. So, upper airway compromises in the nose and nasopharynx may be due to nasal obstructions like bilateral choanal atresia, turbinate hypertrophy, nasal polyps, nasal porine bodies, septal deviations, and adenoidal hypertrophy. Anything in the oropharynx can be due to congenital conditions like cretognathia, glossoptia, that means enlarged tongue, and then the abnormal your mandible, macroglossia, and lymphovascular malformations like lymphangiomas. Anything like acquired causes like hemangioma, angioedema, any allergic reactions, Ludwig's angina, that is again soft tissue infection in the oropharynx and floor of the mouth, any oropharyngeal cancers or tonsillar hypertrophy, or any parapharyngeal or retropharyngeal abscesses can give rise to acquired type of oropharyngeal airway compromise. The most common and important areas, as I told you, are the congenital causes like laryngomalacia. Whenever you are doing pediatric appointments, you will see this condition. It's a congenital condition where you get the larynx, epiglottis, and arytenoids are very ploppy. So whenever you breathe, the tissue goes in, obstructing your airway. The other condition, which I already talked with you, is a bilateral vocal cord palsy. So congenital causes like laryngeal web, you can see the picture. The vocal cords are not separated apart. They are congenital conditions, and whenever childbirth is happening, they will go into cyanosis and acute respiratory arrest. So in that case, you might have to do a tracheostomy at birth. Subglottic stenosis, again, you can see the upper part of the trachea is stenosed or narrowed. Subglottic hemangiomas, again, collection of blood vessel formation congenitally at the beginning of the trachea. They are the causes for upper airway obstruction in lower part of the larynx. So those are congenital causes. If you want to know the acquired causes, they are like laryngeal cancer, infections and inflammations like epiglottitis, subglottic stenosis, bilateral vocal cord palsy, and foreign bodies are the commonest cause of upper airway obstructions, which are acquired causes. So they will present with, as I told you, noisy breathing, voice change, and obstructive sleep apnea pattern. So their breathing during sleep is abnormal. And they will present with features of copulmonale like hypertension, pulmonary hypertension. So if they have a severe signs and symptoms of acute airway compromise, they will have trachypnea. I assume you all know about these words. Trachypnea, that means increased respiratory rate or slow respiratory rate, snipping or tripod position where the patient is leaning forward for air hunger and they are agitated, they are drowsy or confused. They might have intercostal, subcostal, or uh, substernal retractions. When they are breathing, these soft tissue areas retract into the chest, that is called recessions. There can be markedly reduced or no air entry. Tachycardia is a phenomenon and they may be hypoxic and cyanosed. And if there is total obstruction, patient will go into cardiorespiratory arrest. So these signs are very important for you to understand and recognize a person with upper airway obstruction. So how do you manage these type of patients? So you might have to secure the airway, whatever the method. So we'll talk about what are the methods of securing. So you can take a very quick history and examine and diagnose the acute airway compromise. So you have to position the patient upright or prop up position, reassure the patient and monitor the vital signs. So when you see a patient with stridor, these are must. And you can start oxygen 15 ml per minute with the reservoir bag. Your target saturation is generally about 94 to 98 in the most acutely ill patient. And if the patient has a history of respiratory diseases, you are not going to achieve 94 in those patients. Your target for respiratory failure patients are like 88 to 92%. So you have given oxygen with a mask and reservoir bag. You have positioned the patient. You are monitoring the patient. What else you can do? So we are talking about upper airway obstruction with stridor. You can nebulize with adrenaline. Adrenaline dose may be 0.05 ml per kg per dose using 1 milligram per ml ampule. Adrenaline is in 1 milligram per ampule. So you should not exceed more than 5 ml of adrenaline. You can do the repeated nebulization with adrenaline every 15 minutes. So at the same time, you can give IV corticosteroids, either dexamethasone or hydrocortisone. You can give the dose according to 1 milligram per kg, but that will take a little time to act. So your initial management is oxygen and nebulization with adrenaline. Helium oxygen is a mixture which used in other countries, but we do not have this mixture which penetrate into your lungs easily. That's why they give helium oxygen mixture, but in other countries it is available. So that's a medical management. Then surgically, what you can do is with the help of anesthesia team, ENT, and either physician or pediatrician, you can do a gas-induced bronchoscopy-assisted intubation to secure the airway using the rigid bronchoscope. I showed you a rigid endoscope. Similarly, there are endoscopes which can go into the bronchus level. They are called bronchoscopy. So you can use a rigid bronchoscope for intubation with gas induced. You are not going to paralyze this patient initially. You induce the patient with gas which can be recovered easily if you failed. So needle cricothyroidotomy puncture is not much practice now, but cricothyroidotomy is a procedure we do. We take a scalpel blade, we make a puncture in the anterior neck midline in between the cricoid cartilage and the cricoid cartilage where you have the cricothyroid membrane and generally it's a vascular area. So you make a stab injury and you put a small size endotracheal tube or tracheostomy tube for the initial airway management. Then permanently you have to go for a tracheostomy. Laser, electrocautery and balloons are for the centers where they have high sophisticated equipments. So once you do if you do not have the facilities to do anything, what alternative is the needle cricothyroidectomy? You can see you can take a wide bore needle, oral wide bore cannula, and you puncture in the cricothyroid membrane area and connect it into a 3 ml syringe barrel and connect that into a reservoir bag for you to flush some oxygen until you do the proper procedure. So this is the cricothyroidotomy procedure. You can feel the same place and you make a stab injury with the scalpel and rotate the scalpel and insert a small tracheostomy tube or endotracheal tube to enter into the airway. So this is the tracheostomy procedure we do generally as a proper surgical procedure. We make an incision in the neck and go into the trachea and make an incision there and put a proper tracheostomy tube. So if it is a foreign body, obviously there are two maneuvers for you to know. These are called Helminch maneuver, where for adult or children over 1 year, you stand behind the patient and make your hand as a fist and you apply some pressure onto the patient's stomach area with your fist, um, using your fist, so that quick gush of air will hopefully dislodge the foreign body. And you can see here, this is what is called Helminch maneuver. So a pediatric small baby, you can't do that. What you do is actually slap onto the back where the little one is on your knee, or you can make apply pressure on in between the rib cage, again the sepisternal area. So you can see these pictures, what you are supposed to do. So that's about the larynx. If we move into the pharynx, pharynx is again a fibromuscular tube, which I don't want to discuss too much about that. So it is it gives opening to the esophagus. You can see the pharynx area, which I'm not going to talk about the anatomy here. So the important thing here is the Waldeer's ring, the collection of lymphoid tissue that has the pharyngeal tonsils, palatine tonsils, tubal tonsils, lingual tonsils. So what we see in the nasopharynx is actually, they are called pharyngeal tonsils. They are called the adenoids as well. Then you have the palatine tonsils that you normally see on the mouth. Right. See, these are the palatine tonsils. You can see the tonsils. So at the nasopharynx, you can see the adenoids or pharyngeal tonsils. So clinical correlations, if you get an enlargement of the palatine tonsils or the general tonsils, you can get odynophagia or dysphagia. And then you can get if there is a problem in the sphincter of the esophagus, you can get Schenker's diverticulum. So that is the outpouching of the mucosa of the pharynx. These things are too much for you. Tonsillitis, obviously you have to know. Tonsillitis is the infection of the tonsils. It can be bacterial or it can be viral. You can get the retropharyngeal abscess formation where you get the infection into the pharyngeal space. They're quite significant because they can get airway compromise with the abscess formation. You have to drain them either through the neck laterally or through the oral cavity. So the tumors in the ENT, obviously you have to know. Tumors are common among tongue and the larynx. So the etiology factors are tobacco, alcohol, dental, like dental factors like unhealthy dental mucosa, occupational exposures and infections. So many things are there. So I don't think you should talk about that. The oral cavity, one of the common area is the lip, and it's specifically males are affected, probably due to their smoking habits. Nowadays, maybe in future, things might change. The commonly affected areas are midline, lower lip, and then the upper lip, and then the edges. So they might present with significant ulcers. The commonest are the squamous cell carcinoma, and cigarette smoking is one of the pipe smoking is one of the commonest reason. So if you move into the tongue you can get carcinomas, commonly the lateral part of the tongue, then the tip or posterior part is rare, and they are generally coming into the lymph node. So they might come with the ulcer and lymph node in infield secondary deposits on the lymph nodes. They are generally painless and they are indurated masses with as ulcerated. So if you move into these are also squamous cell carcinomas most of the time. And if you move into the nasopharynx basically you can get nasal bleeding or eustachian tube blockage and secretory otitis media are commonest presentations of nasopharyngeal carcinomas and ear pain. So if a patient is there with unilateral secretory otitis media and ear pain is there without significant signs and symptoms and signs over the ear, you have to think about the nasopharyngeal carcinoma as well. So the commonest are those. I talk about the laryngeal carcinomas in the previous slides. So take home messages of ENT area on this one is upper airway obstruction is a must that you have to know. Head and neck malignancies may present in advanced ages because of the unawareness of medical team for proper early diagnosis. So you have to be aware voice change or any dysphagia, voice change more than 2 weeks, any dysphagia significant more than 2 weeks, odynophagia, breathing difficulties, secretory otitis media, unexplainable otalgia may be the presentations of these head and neck tumors and cervical lymph node enlargement. So be aware of these unusual presentations and refer them for proper examination. So proper examination of the head and neck area is mandatory for early identification of malignancies. Okay, so that lecture is over. Any questions? I assume you all can talk now, or if you want, you can type as well. Do you want me to continue for the pharmacology lecture, or you want a 5 minutes break? What do you want?